Hi, my name is Ben, and I'm a health educator at the Hospital Research Foundation group Arthritis, and I run our webinar series. To start this video, the Hospital Research Foundation group Arthritis would like to acknowledge the traditional custodians of the lands across South Australia and pay respects to the elders past, present, and future. We recognise and respect the unique cultural and spiritual relationships to the land, waters, and seas, which continue to be important to Aboriginal and Torres Strait Islander peoples living today. Over 2023, we've hosted 10 different webinars about a wide range of topics around arthritis with world-class experts. This video features short segments from all of our webinars. There will be links to each of the webinars to watch in full, so click on those or scroll down to the description below. We will continue to host webinars across 2024, so keep an eye out on our social media or sign up to our e-news to hear about them first.
The key is to slowly but surely increase your activity level over time. And here's a diagram of what this might look like for a graded walking program. So in week 1, you might go for 3 walks to find your sweet zone. This means how far you can walk before you experience a significant increase in your pain, or pain that is likely to last for some time after you finish walking. We usually say around 2 hours or more. And then once you've completed your 3 walks, you calculate the average duration, and that's your current sweet zone. So for example, if you walked for 8 minutes, 10 minutes, and then 12 minutes, your sweet zone would be 10 minutes. Then in week 2, it's a good idea to start a little bit below your sweet zone to give your body time to adapt to your new routine, especially if you haven't been doing much activity before you start this sort of program. So if your sweet zone is 10 minutes, in week 2, you'll do 4 to 5 walks that last for 8 minutes, which is 80% of that 10-minute sweet zone. Then each week you progress by increasing the duration of your walks by 10% until you reach your goal. We usually recommend 5 30-minute walks per week as a good goal to set, because this is the activity level recommended by the Australian government and experts for health benefits. So it's all about gradually increasing your activity level so your body has time to adapt. And it's really important to stick to the plan despite how you're feeling. So this means not doing less than planned, even when you're having a bad day, but it's also equally important to not do more than planned, even when you're feeling really good, because this can push you into the too much zone before you even realize. So when increasing activity, you might get a slight increase in pain as your body adapts. But what's really important to remember is that this pain does not mean you've damaged your joint. It's just our body's way of telling us that we've overdone it a little bit. And this is why it can sometimes feel like exercise is not working for you and it's making your pain worse. But it's all about recognizing that some fluctuations in pain is normal, especially when you're starting out and figuring out your unique sweet zone. And as you can see, this is no quick fix. It does take time and consistency to reap the benefits of an exercise program. But research is clearly showing us that people who stick with these sorts of programs can have life-changing results, just like Peter did. In fact, this is the actual walking program he completed that took him all the way to the Camino Trail in Spain. It's also really important to make sure you choose activities that you enjoy, because you're much more likely to stick with the program and keep doing that activity over the long term. So most people choose walking because it's free and you can do it anywhere. And it's so important for our daily lives to be able to walk distances, for example, walking around the shops. But you can apply the sweet zone principles to any activity: cycling, swimming, strengthening exercises, you name it. Setting short-term and long-term goals are also a really great way to keep yourself on track, motivated and accountable, and also to feel that really great sense of achievement when you reach your goals, just like Peter did. And finally, recent advances in pain neuroscience have shown that so many different things can contribute to the pain that we feel, not just what's happening in the painful joint. So some of these might seem quite surprising. For example, the things you hear, see, smell, taste, and touch, things you do, things you say, things you think and believe, the places you go, and the people in your life can all have important influences on your pain. Some of these can be negative and increase pain. We call these DIMs, or danger in me. But also some of these can be positive and help reduce pain, and we call these SIMs, or safety in me. So for example, have you ever noticed that your mood can have an impact on the pain you're feeling?
So what is rheumatoid arthritis? It's an autoimmune condition, which means that the body's natural defense actually attacks itself. And the first thing it attacks is the lining of the joint, called the synovium. But it also can attack other parts of the body, such as the lungs and the skin, and really the heart as well. So there's many different symptoms, and around the joint, they can be pain, swelling, warmth of the joint, which indicates inflammation. Patients often complain of stiffness, especially if they've been sitting in one spot for a long time or in the morning, and that actually gets better as the day goes on and they start to move their joints. And fatigue is a very common symptom, especially when arthritis is active. One of the holy grails of rheumatoid arthritis is finding out why this occurs. And we know there is a small impact of genetics. We know it's more common in women, and we know it does increase with age, but it can affect all age groups. And some lifestyle factors such as smoking and weight also can contribute as well. So this means around nearly 2% of Australians have rheumatoid arthritis. But you'll see from previously untreated rheumatoid arthritis caused a lot of joint deformity. And really if you took 100 people off the street, you wouldn't notice that many of them have rheumatoid arthritis, because now it's more of a hidden disease because we've got so much better at preventing the joint deformity. But that doesn't mean people are not impacted by pain and fatigue and other symptoms. So what's happening in the joint? You can see on the left a healthy joint with the blue there, which is the cartilage. And then you can see the lining of the joint in the pale pink. And inside the joint, we have a small amount of joint fluid, which sort of lubricates the joint and keeps the cartilage very healthy. But what happens in rheumatoid arthritis is that lining gets swollen and inflamed. And if that's left over a period of time, that can start to form what's called pannus, which is a lot of inflammatory material in the joint, and that can start to erode into the bone and into the cartilage. And once those things have happened, it's actually irreversible damage. While we've just got inflammation in the synovium, that's actually reversible. So that's when we want to treat people really early with their disease, so we can get it while it's still reversible, and we can get on top of that inflammation. So as I just mentioned, early intervention is the key. So if people have early signs of rheumatoid arthritis, seeing your GP, getting a referral to a rheumatologist is really key, because the sooner you can get onto some good treatment, the less likely you are to have long-term damage from rheumatoid arthritis. We know medicines that we use can help slow the condition and definitely make you feel better, reduce the inflammation, reduce the pain. And also non-medical treatments, so some can help actually improve people's function. So that's how well you move and function in everyday life. So things like that include physical activity, diet, adequate sleep, and also having a good work-life balance. Work and family life can be quite tiring, and pacing yourself is really important when you've got a chronic illness.
review that was done in 2009 that I also showed you looked at different dietary interventions and those dietary patterns. And they saw 5 that provided some benefit. So the first one was a low meat or a plant-based or a Mediterranean diet, all roughly the same thing. And what they're able to show, an RCT from Sweden showed benefit on a Mediterranean diet for 12 weeks for just one study. They showed improvements in a lot of those self-assessed health questionnaires related to rheumatoid arthritis. They also showed reduction in inflammatory activity, improved physical functioning compared to the controlled diet, but this only became evident after about 6 weeks of consuming the diet. That's why we say you need to give things a bit of time to help the body to change to the new areas. And this dietary pattern is thought to work because the high level of monounsaturated fats, also the high level of antioxidants you're consuming through all the plant foods you're eating, and a reduction in the meat intake, saturated fat, and also ultra-processed foods. The second the rest of these dietary patterns actually are all a bit, difficult to follow, but they did look at them. And one of them was an elemental diet. And that's when you just simply consume amino acid, carbohydrates, and fats, not as food. So quite a horrible diet. And I'm really pleased to say that they found no difference in that, because I would hate to put someone on one of these sorts of diets. Then the third diet pattern they looked at was an elimination diet, where they tried to get rid of all the really allergenic foods that occur in the diet. And this was only one study. They did those that were in the experimental study in the elimination diet did do a little better, but not much better. But it was also really badly executed study. And once again, this diet is really difficult to eat. It's very plain. It's basically, steamed chicken with fruit like pears, potatoes, rice, white bread. So it's really bland, almost a white sort of diet, because it doesn't contain any allergens in it, and very difficult to follow, and also not very enjoyable. And then the fourth pattern they looked at was the vegan diet. This is somewhat similar to that really high plant-based diet or Mediterranean diet, but there was no animal protein in it. And there's only been 2 studies that have looked at that. And they compared 12 months of a vegan diet to ordinary diet. And there was about 20% improvement in signs and symptoms, but that wasn't statistically significant. And it was also, once again, poor quality studies. And then the last pattern they looked at, which is hardly a dietary pattern, because it was fasting, for 7 to 10 days and then 13 months on a vegetarian diet. There was 2 studies that looked at that, and they found moderate improvements in pain. And fasting's always been something that's come up. A lot of people ask about it. And we generally don't recommend fasting because of the problems. Well, there's many problems. The first one is if you go into a fasted state, the medications you take are going to act a little bit differently in your body. So you need to talk to your doctor about that and about which medications you may need to change or stop or alter. So it's a little bit dangerous from that perspective. But also it's not highly sustainable. There are a lot of sort of fasting intermittent dietary patterns that people consume, where they try to have the 5 and 2, where they eat more on 5 days, they eat normal amounts in 5 days and eat a little less on the other 2 days. And those are probably okay to do. But once again, you do need to talk to your doctor if you're on medication for anything for those. So the pattern that came out the most successful and perhaps the most palatable for people in all of those was the Mediterranean diet pattern. I just want to look a little bit more closely at what the Mediterranean dietary pattern is. Now, most people think it's gyros, which it's not. The other thing people think is you can just pour a bit of olive oil on all your food, and it's not that either. So let's have a look. When people do follow, and I guess the benefit is we do see lower patterns, risk and prevalence of rheumatoid arthritis and osteoarthritis when people follow a Mediterranean diet. But even if the evidence isn't of that high quality we're after, what we also know is that it also provides benefits in a whole lot of other conditions, which some people may have along with their inflammatory conditions. So metabolic syndrome, it provides benefit for heart disease, it lowers blood cholesterol, it lowers blood pressure, It can reduce the severity of obesity or overweight. It can reduce your risk of getting diabetes or improving your glycemic control, your glucose levels if you have diabetes. It provides cognitive benefit. I've got depression there, but we also know now it actually improves your cognitive ability as you get older, and it also reduces the risk of death. And the impact on these conditions is quite marked with the Mediterranean diet.
So complementary medicines are medicines that are not part of standard medical care, but they are used in addition or to complement standard medical treatment. They can come in many, many different forms, including tablets, capsules, liquids, oils, drops, teas, powders, etc. And complementary medicines are different from prescription or over-the-counter medicines. They can be self-selected by the consumer, and they can be purchased from local pharmacies, health food stores, herbalists, naturopaths, supermarkets, or even over the internet. And often we find it can be quite easy to forget to tell our health providers that we are using complementary medicines, because sometimes we don't think of it as a medicine, but it is really important to let them know about every medicine we use, including these herbal products. We do consider complementary medicines as a medicine, and like all of them, they can have some benefits and they can have some risks, including side effects, allergic reactions, or even interactions with other medicines and health conditions as well. So we thought we'd just touch on how medicines are approved in Australia. So there's an organisation called the Therapeutics Goods Administration, which is also known as the TGA. And this is our Australian government organisation who's responsible for regulating therapeutic goods or medicines and medical devices, all the way up from prescription to complementary medicines as well. Once medicines are approved by the TGA, they are then included on the Australian Register of Therapeutic Goods, also known as the ARTG, and many of these complementary medicines are included on this register. So when a medicine is registered by the TGA, it'll be given a number, and it's often either an OST-L or a listed number, or an OST-R, which is a registered number. If a medicine has been listed, so OST-L, it has been assessed by the TGA and approved for safety and quality, but not necessarily efficacy. So the TGA have not assessed the scientific evidence for the medicine's claims before it enters the market to be sold. And as a result, the products can only make very low health risk claims. For example, you might see things written like, this product may help with arthritis. So using the word may is a very common term they use, as opposed to saying this product will treat arthritis. And many complementary medicines will be listed medicines. If a medicine has been assigned an OST-R number, so a registered number, the TGA has assessed the medicine and it has been approved for not only safety and quality, but also for efficacy. The assessment and regulation of registered products by the TGA is quite rigorous and detailed, registered, but not all registered medicines are prescription. So for example, our commonly over-the-counter medicines like paracetamol or Panadol, or ibuprofen, which is Nurofen, these are registered products, but obviously they're not necessarily required to have a prescription to obtain. So what about medicinal cannabis? And this is a really common question that we get asked here in Medicines Information as well. There is only one medicinal product approved in Australia, which is licensed for severe muscle spasms in people with multiple sclerosis, and also for severe epilepsy in really young infants. The other conditions it's unapproved for in Australia. Research so far shows that only a small number of people treated with these cannabinoids or medicinal cannabis for painful conditions notice a small improvement in pain and sleep, and there is little or no improvement in their ability to participate in daily activities. Also, research shows that many people can experience unpleasant side effects. Some of them are mild, so such as nausea, dizziness, or difficulty thinking clearly. But there may be other important side effects in the long term that we just don't know about yet. Again, these side effects will be quite different from recreational marijuana, which can depend on how you're actually using it. So for example, if people were smoking marijuana, you are more likely to have things like chronic bronchitis, because obviously you're inhaling it into your lungs. Many cannabis products may also prevent people from driving and operating machinery, which I think is something that people don't always appreciate, which before I really appreciated as well. It wasn't something I considered. For example, it is a criminal offence if you're found to have THC in your bloodstream while driving, and you will lose your license. So it's just something to bear in mind if this is a path you want to explore. Medicinal cannabis can potentially interfere with many prescription medicines, such as blood thinners, medicines for epilepsy, opioid pain relievers, just to name a few. There are many, many more as well. And I guess overall at this stage, the Australian Rheumatology Association does not recommend medicinal cannabis for arthritis or any other related conditions as well. The other thing to bear in mind is medicinal cannabis can be quite costly. We've been told figures range from about $200 a month. I've certainly heard of over $1,000 a month, depending on the type of product you get as well. So it is another thing just to keep in the back of your mind.
Summarize, gout's caused by a high urate level, and we call this hyperuricemia. And that leads to the formation of crystals, and that can be both in and around the joints. So it can also be in things like tendons and soft tissues and stuff like that. The important concentration, I know this sounds awfully technical, but people with gout will remember these numbers because people like me keep on parroting sort of the urate concentrations back at them all the time. And but that concentration of urate in the blood has to be at least 0.40. And effectively then, the blood can become concentrated with urate to the point where crystals can form. However, people can walk around with urate levels of 0.60 and never have any symptoms or signs or features of gout ever. So there are clearly some individual factors in who gets crystals and how they respond to the presence of those crystals. But in general, the higher that urate level goes, the more likely you are to get gout. So diet is important, and I think that certainly is part of treatment, but it's not the entire picture, and people need to realize that this is actually an inflammatory arthritis and there are very good medication to help them. So in fact, rather than diet, a more common cause of, the most common cause of gout rather, is reduced excretion of urate. So as mentioned before, the majority of urate leaves the body via the kidneys. And so certainly I see a lot of patients with chronic kidney disease, and they've lost that, 100% of the urate in the body is initially filtered out through the kidney, and then there's complex reabsorption and within the actual kidneys themselves. But the reality is, if you're not filtering the urate out as well as you should through your kidneys, then you're at increased risk of developing gout. There are also some medications taken for certain medical conditions that can contribute to retention of urate through the kidneys, and that includes, surprisingly, low-dose aspirin and also commonly used are diuretic medications as well, either diuretics for fluid retention or diuretics as part of blood pressure medication. The most important thing, however, and the problem with gout treatment in general in the community, is the focus is largely on just treating flares, and then that patient often just disappears, and then they come back to their local doctor when they have another flare. And really, as you'd appreciate now, their urate level is still elevated, and they still have crystals in and around their joints, and nothing has really changed. In the interim, they've still got those crystals sitting there, and they've got inflammation rumbling away. So the most important element of treatment is, in fact, lowering the urate level and dissolving the crystals. And what we're trying to do is gradually bring down the urate to what we call serum urate target. In other words, we're trying to get it at a level below the point where the crystals can form. So as I said before, that number of 0.40, we want to get it below that. So the target's really arbitrary, and guidelines say different things. They say at least lower than 0.40, 0.36. I choose 0.30 because my experience and with the research that I've done, and following patients with ultrasound studies and things like that, you might be there forever and a day if you choose that higher target. So in other words, we're getting the concentration down to a suitable level where the crystals are going to dissolve, not too fast, and there's a reason for that, but also not so slow that it's going to take the next 10 years. The dose of allopurinol, and this rarely happens, can go all the way up to 900 milligrams a day. One of the main problems is, of course, when people get started on well, first of all, the problem is people getting started on allopurinol in the first place. But the second problem is that doctors don't then sequentially measure what the concentration is and increase the dose appropriately. So you'll often see that people are started on either 100 or 300, and they stay on that, regardless of what it's doing for them. And it might bring down their urate level, but it might never be below 0.40, and therefore, they're still going to accumulate crystals, and their gout's going to get worse. So, does allopurinol have any side effects? Very rarely. Very rarely. So like anything, you can have an allergic type reaction, just like you can to things like penicillin. We call this allopurinol hypersensitivity syndrome. I haven't seen this full-blown syndrome in anyone so far that's come through my clinic, but it's very rare. And it's something that usually happens in the early going in the first 2 to 3 months. It's characterized usually by a rash, and I tell my patients if they get a new onset of a rash when starting allopurinol, they're to stop it and immediately let me know. But it can be even life-threatening and affect the internal organs. That's extraordinarily rare. And the reason for that, and it's becoming sort of increasingly rare as well, because in times past, we often, not myself, but rheumatologists in general, doctors in general, started on a higher dose of allopurinol thinking that, well, we need to put someone on a higher dose to bring the urate level down. So it appears that our approach, a more modern approach, of starting off on a low dose and then gradually increasing it, reduces that risk. Also, there are some genetic predispositions that we can test for in certain patient groups. And that's a specialized test, but it can be done. And that would tell us if someone was positive for that certain marker, that we would actually start them on a different medication. And as I said before, I just generally tell people if they get a rash, that's when they stop it.
Now, the quote, I think, reflects the fact that for any of us, if we're embarking upon exercise as medicine, the first step is really hard. And even if it is a very modest, tiny first step, I think we never need to underestimate the fact that it is difficult and it is hard. I think just using the reasons that I stated as all the medical reasons, I think is a bad reason to start. I think you need to set a goal, and the goal needs to be where you want to be in 6 or 12 months' time, where you want to be in 10 years' time. And that's where exercise best fits in. There's no doubt you and your GP might decide to take some bloods, or you might decide to check your blood pressure, your blood sugar, as parameters of how the exercise is helping in a positive way. But the goal, I think, should be a functional one, and it should be your goal, not mine. The next, of course, that I always hear from patients, they don't have enough time. Everyone's busy, but just remember, in a week, you've got 168 hours to play with. And, there are a number of things that are non-negotiable regarding sleep and work and eating and family and friends. But there is still time available, discretionary time. And I think when you're investing in your health, it's critical. It might be the first step is a very, very modest allocation of time. If you do a Google search, there are both American and Australian guidelines that suggest that you should be allocating 30 minutes on most days of the week. But for some people, that's a huge step. That's a mountain. So it might be that the first step is 5 minutes on alternate days, and that's fine. I think the activity to begin with doesn't really matter. You have to enjoy it. There's no point in, hearing that, oh, well, Pilates is the answer, or yoga is the answer, or Tai Chi. If you don't enjoy those activities, it's most unlikely that you will continue them. So I think the activity needs to be something that relates and resonates with you, and it also probably needs to consider, one, where your health and your physical fitness is today. And it might be that you begin your exercise routine in a chair, and that's fine. So it has to be manageable, but it also has to be of interest to you. There's nothing worse than doing something you don't enjoy. There are a variety of ways to actually improve compliance, that is, improve the likelihood you're still doing it in 6 months' time. And some of them are quite surprising. Exercising before lunch, you're more likely to stick with, believe it or not, than if you try exercising in the afternoon or evening. Now, some people, their lifestyle will only allow them to have a little program in the evening, and that's fine. It's just that the research shows us that you're more likely to stick with something before lunch than after. There's no doubt you've got to enjoy the activity. And when I say involve a friend, it's very, very tough trying to be disciplined and be a lone wolf. For some of us, that's fine. And for some of us, that's the only option we have. But the minute that you get a friend involved as well, you're far more likely to stick with it. And that friend might be four-legged and furry. And there's no doubt there's some quite interesting trials that have shown that if someone starts a walking program, if they happen to be walking with their dog, they're far more likely to be doing it in 6 months than if they're not. So, as I said, the friend can take all sorts of forms, but it's often important, and it can make it enjoyable, because it's not meant to be a sentence, and it's not meant to be punishing. And I think the important thing as well is, once you've got the all clear from the GP, if that's appropriate, it's so easy to put this off to tomorrow or next week or next month. But if you want to be doing something interesting at the end of the year that is difficult or impossible at the moment, you have got to start today. And it might be a tiny step, it might be on alternate days, but I think if you leave it for tomorrow or the day after, it's often hard to get going.
So let's go back to this assumption that I started my talk with, this idea that the pain we feel, it only reflects what's going on in terms of our tissues, damage or injury to the tissues. Now, what I've shown you, all these different examples, they illustrate clearly that that isn't the case. It is not just what's going on in the tissue, because the exact same laser zap can hurt more or less, or the electrical zap can hurt more or less. So instead of this idea that pain just reflects what's going on in the tissues, what we realize and what neuroscience supports is that we all have a dynamic system. And this dynamic system adapts and it updates based on the available information around us for that person, in the environment, whether it's stinky or not, and within the society. And this system is about protection, because pain is actually a really great way to protect ourselves. We don't like it, but what does it do? It pulls our attention. It stops us from doing something. It makes us change our behavior. So this dynamic system is about protection. And ultimately, what it's doing is taking all the different available information of danger and weighing it up against all the different available information of safety. And it's often the balance of these that determine how much we hurt. Now, an important extension of this is that if there's lots of different contributors to pain, then it suggests that anything that gives us information that we need to be protected or that we're in danger or there's threat can potentially increase pain. And in contrast, anything that suggests that you don't need protecting, that you're not in danger, that you're safe, can theoretically reduce pain. Now, I want to bring forward why this might be important by going a bit more in depth into what we know about osteoarthritis. And really, I think, explore why this concept might matter. So if we look to what people with osteoarthritis have been told and ask them, what do they think about their osteoarthritis? This is what we see, is people will report that I have osteoarthritis because my joints are worn out. It's a wear and tear disease. And the reason that I hurt is because my joint is bone on bone. There's no cartilage left. So because I have this worn out joint, it's vulnerable. And that I've been told that it's only just going to deteriorate or get worse over time. So yes, I know I've been told that I should probably exercise more and that activity is good, but I don't think that applies to me, because I have this vulnerable joint. Loading the knee could cause more damage. So actually, I probably should be careful about how much activity I do. I don't want to wear out my joint further. And also, I don't really have any cartilage left. So surgery really is the only option because I need to replace that cartilage. And if we explore beliefs a little bit further about movement and exercise, people will say things like, it seems common sense that if you've got a deterioration in the joint, like which arthritis is, then the more you do, the more it's going to be worn, I wouldn't have thought it's something that would get better with practice, with exercise. Or if it's your bones that's grating together, causing that much pain because there's wear and tear, how is the muscles above or below really going to help? That's completely valid, isn't it? Completely. And if we think in this sense, if we remember the previous information that I gave you, what happens when we aren't sure if something's safe? It hurts more. What happens if we aren't truly convinced that exercise is safe? Everything's on high alert, and the same thing has potential to hurt more. So what I would argue is I would agree. Advice to move makes absolutely no sense unless one understands that osteoarthritis is not merely a wear and tear disease of the joint. It's not just about the joint, because ultimately, that's actually what the new science is showing us, that all of these things that people have been told and that they think about osteoarthritis, some of these are myths and misperceptions.
Interestingly, all of these stress response behaviors are linked with pain and arthritis. So the very things that some of us are doing to cope with stress could also be contributing to the development or ongoing symptoms of our arthritis conditions. Now, this slide is a bit of a summary of how chronic stress can get under skin and influence our health over time. So that concept of allostatic load that I mentioned before. So we start with a potential stressor, and the pivotal question is that stressful to me? If so, there is perceived stress. We remember that all of this is influenced by our individual genes, past experiences, and the current situation that we're in. That perceived stress leads to physiological responses like increased blood pressure that we discussed before, and also behavioural responses. Furthermore, those behavioural responses can then create more physiological changes. Over time, if the stress continues, these stress responses lead to long-term changes or allostatic loading that can then affect our health. Okay, so the good news is there are lots of things that we can do to counteract this stress in our lives and to reduce that allostatic load. And Sally's going to talk more about these after.
So some practical tips. To start with something small. You don't need to do everything all at once. Quality over quantity is important. So be consistent and don't try to do too many things. Doing one thing is plenty if you can start to implement it and make it part of your daily life. Focus on strategies that feel best for you. Prioritize stress management, just like you would other forms of healthcare, and connect it with something else you already do. So, you know, if you like, and we'll talk about things that we can do, but if you like music, put it on while you're getting ready for your day. You know, incorporate it into your life. So it's not an extra task. It just becomes the feel-good part of the things that you already do. How many times have you been told that reducing stress is good for you and that eating a healthy diet is good for you and that exercising is important? And how many times have you found it difficult to make a change and actually stick to it? And why do you think this is? Do you think it's about laziness? Do you think you lack motivation? Whenever we're considering a behavior change, the most crucial but often missed step is to explore how our beliefs influence our thoughts about the issue. So take a moment and ask yourself honestly, what do you actually believe about stress? What do you believe about investing in stress management strategies? And where does it sit on the ever-growing list of important things you have to do every day? If we're really honest with ourselves and we take some time to write down our beliefs without judgment, what we usually find is a whole lot of lessons that we learn from other people. Some of them are helpful and some of them aren't. Some beliefs I've heard are, I don't have time to look after myself. It's too hard. I have other responsibilities that are more important. It's selfish to do things that manage my stress. Or, no, I feel lazy if I'm doing those sorts of things. You might have something else that goes on for you. But I want to challenge those things because a lot of them came from places that don't really fit with the lives that they're leading now. So in order to do this, we need to make good choices. Okay, recognizing I have a choice here, getting curious with what that might be, what your automatic response is generally. Where does that usually land you? If you take the same steps and take the same action that you always have, where are you going to end up? Probably in the same place that you are now. So how could I make a different choice? And how might that impact on my well-being? A big part of engaging your parasympathetic response in your nervous system is to find what feels good. And what comes to mind when I say that? A lot of us have lost touch with what feels good. Our days are full of pain, fatigue, responsibility, frustration, and repetition. Some people have learnt to feel good by serving others, prioritising things outside of themselves, family, work, household tasks, the things that positive stress helps us to do, the things that feel non-negotiable, that we wouldn't question whether they need to be done or not. But the result of this is that we spend so much time and energy doing these things that we lose sight of what feels good for us, our mind, our body, and our spirit. Stress can cause life to feel fast, heavy, chaotic, overwhelming. Stress can make us feel buzzed, agitated, under pressure, and can result in a rush. What do you think is happening in your nervous system? Sympathetic response is being activated. Introducing breathing as an experiment is a good way to experience your parasympathetic response. If you take even maybe 3 or 4 breaths, just with the timing of this image, what you might notice is that everything just slows down a little bit. If we think about our nervous system having that response, then what we're giving it is permission to just slow down for a little bit. And that's what we want. That's that parasympathetic response engaging, and that's what's going to help recalibrate our system.
% of people survey draw sleep like this. So just to give you a bit of information about the graph that we have here, across the bottom, so this bit along the bottom where we see 0 to 8 is the amount of time from your bedtime. So lots of people associate getting enough sleep or good sleep with getting 8 hours a night. Whether that's true for everybody or not is something we can unpack in a minute. But what we also see on this left-hand side is moving from being awake into some lighter sleep or some dreaming sleep, and then, into slightly deeper sleep, with stage 3 being this very deep sleep. And most people think that our sleep pattern should look like this, that you should get into bed and pretty quickly you should start off in light sleep, go off into some very deep sleep, get that deep sleep that everyone tells you is really important for feeling well, and that you gradually come back up towards being awake after a nice solid 8 hours of what's predominantly deep sleep. And actually, the reality is that that's not what normal or healthy sleep looks like. In many respects, it's actually not healthy for us to go to sleep and then not have any awakenings overnight. And this usually comes as a little bit of a surprise for many people, because what our sleep actually looks like and what healthy sleep looks like is a little bit more of a roller coaster. So this is the same graph again. So along the bottom, you've got bedtime and then the number of hours that you've been asleep moving across the bottom. And again, we're going from being awake when you go off to bed and fall asleep all the way down into that deep sleep, which is what we call stage 3 sleep. In Sleepwell, we're very, very creative with our labels. So we go from stage 1 to stage 2 to stage 3. And then REM sleep is that rapid eye movement sleep or dreaming sleep. And so what we actually see is that our sleep happens in cycles. And the thing that usually surprises people is that it's extremely normal to wake up during the night and have brief awakenings and then go back off to sleep within, sort of 10 to 15 minutes. There's not anything wrong with your sleep if you wake up sporadically and get yourself back off to sleep. And there's probably an evolutionary reason that that would be healthy, because particularly if we are responsible for making sure our environment's safe, then that's a really important part of being asleep. If we were vulnerable enough that we went to sleep and just slept deeply until we woke up 8 hours later, that would probably have some implications for humans and survival, particularly back in the day. So we know that this number of 8 hours, or getting between 7 to 9 hours of sleep, is commonly sort of thought of as the ideal sleep duration. The reality is that lots of people have various sleep needs. So some people will often find they need 9 or 10 hours. That 10 is probably getting a bit higher on the level there as a healthy adult. But, some people seem to need less. And one of the kind of rules of thumb, or if you like, or an easy way to sort of have a think about whether you're getting enough sleep, is whether you need an alarm clock to wake up every day. So often that's one of the first questions that we ask is, do you need an alarm to wake up? Is it hard to wake up in the morning? And that can be a little bit of a test as to whether, you're getting enough sleep in that previous sleep period. So the other thing that we know is that in addition to this kind of roller coaster of sleep, moving through the cycles of sleep over the night, there's usually about 5 of these kind of dipping cycles over the night. Is in addition to that, we also know that people need this sleep at slightly different times. Sometimes you'll hear it referred to as night owls, or an early bird. And what that actually reflects is something that we call chronotype. So some people do seem to do better if they can get up in the morning early and then go to bed early. I'm one of them. Other people seem to do better if they go to bed later at night, but then are able to sleep later into the day. And that would be my husband. So, there are definitely examples where the people in our household can sort of work on different schedules and different timing for that ideal sleep. And again, that probably served a pretty important purpose. We do need some people to be up early in the day, doing morning tasks and taking care of the community. Whereas, we also need the evening types to be taking care of the nighttime watch and looking after evening activities. So it makes sense that we are all a little bit different in terms of when what we call our internal body clock works. So that's the clock that gives us, that signal of whether we like to go to bed early, or whether we're somebody that perhaps stays up a little bit later at night. So that's kind of the 2-minute version of what that looks like in terms of our body clocks, but just a reassurance as well that, it can be very different. Some people can be, prefer to stay up late at night and that works for them, and others can prefer to go to bed early. And those can be normal. There can be extreme versions of needing to go and get your sleep really early at night, or going to bed really late, so into the early hours of the morning and having trouble sleeping before then. And they're actually what we call circadian rhythm sleep disorders. And certainly one of them, the one where people go to bed quite late, so 2, 3, 4 o'clock in the morning and need to sleep later, can be quite disruptive when you're trying to get up to, to go to work and fit in with society. So there are a range of different treatment options for people that have that, what we call delayed sleep-wake phase disorder. So a very big name for saying they have a really late clock and seem to get their sleep, sort of early in the morning, and then sleeping in later is ideal for people with those sort of later clocks. So the other thing that we know is that your sleep changes over as you age. So, for example, infants come out with very unclear sleep patterns. It takes them a little while to adjust to the day-night sleeping pattern. But that also, those changes in our sleep continue as we age. So you can see on this graph, we've got sort of 8 hours of sleep onset. That's kind of that rough rule of thumb, or the mean value of how much sleep people typically get per night. But as you get older, we see that people seem to need less sleep. So there's only that kind of 7 hours on that graph now. So 0 as bedtime and then up to 7 hours. And then with age, we also see more of those awakenings overnight. And again, what we're talking about here is what we would say healthy sleep. There seems to be more awakenings earlier in the night. It can become challenging or problematic for people if those wakings at night are more challenging to get back to sleep. And I'll cover that a little bit more in a little bit. But more that reassurance that actually as you age, it can be normal to wake up more during the night. And as long as you're able to get back off to sleep, within sort of 10 to 15 minutes and it's not causing you distress, then absolutely that can be normal.
As you can see here, it affects 1 in 7 Australians. This is from the recent government data. But really, I think it probably affects more than this number of people, because I think there's a lot of undiagnosed arthritis in the community. It's the second most common long-term health condition, and also the second most common reason why people have early retirement due to ill health. There's over 100 forms of arthritis. And the Hospital Research Foundation Group Arthritis is here to help any South Australian with any type of arthritis. And I really encourage you to either visit our website or call our free information line. The number's there, and it's open 9 to 5. And we've got 2 wonderful health educators who can answer your questions and direct you.
I get out in the community a little bit. It's so what are the causes of the aches of osteoarthritis, if specifically in osteoarthritis? And they're asking more specifically if there's no inflammation involved at that time period.
Yeah, so osteoarthritis, the hallmark symptom and sign of osteoarthritis is actually reduction in cartilage. But the conundrum is cartilage actually has very few pain fibers in it. So why do we get pain from that? What we've learnt over recent years, when we've started doing, we used to do just x-rays for osteoarthritis, but now we're starting to do, in research anyway, we've been starting to MRI scans, which can look much more closely at the tissues. If we look at the tissues underneath, we can also see that there's some lesions and there's some bruising almost in the bone underneath the cartilage. And we know that people who have more of those bone bruising actually have more pain. And bone actually has a lot of pain fibers. We also know that although osteoarthritis is not very inflammatory like rheumatoid arthritis, it is a little bit inflammatory. We know that from when we do biopsies, and that the more inflammatory it is, the more likely you are to have pain. There's a lot of research going on at the moment to try and treat those bone lesions, because we think that will help with the pain. In my unit, we've done a couple of studies trying to treat those bone lesions, but unfortunately it didn't. The drug we just tried to use didn't actually work that well.
Perfect.
But there is a lot of work going on at the moment, and certainly everyone's looking for ways to improve pain in osteoarthritis.